Yeah, that's fine. So hi everyone, my name is Ben. I'm one of the acute medicine SHAs at Charing Cross and Still. Today I'll be discussing the management of decompensated cirrhosis on the acute medical tape. I'd like to thank Dr. Selvapatt for his input in the production of this presentation. So the content of this presentation is that we'll be discussing the importance of decompensated cirrhosis. We'll be discussing what cirrhosis is, and what do we actually mean when cirrhosis is decompensated. So we'll be discussing both compensated versus decompensated cirrhosis. We'll be discussing the prognosticating in cirrhosis using the MELD and Charles-Pugh scores. We'll be then walking through a case which will use an important clinical tool called the decompensated cirrhosis care bundle. And at the end of the presentation, I'll give you a small update on the medical mystery from Afghanistan, which one of the acute medicine F1s, Izzy Williams, kindly did a couple of weeks ago. So just to give an update on that patient. So why is cirrhosis, and in particular decompensated cirrhosis, important? So the NCPOD audit identified that only 47% of patients with decompensated cirrhosis receive good medical care when they are admitted to hospital. And decompensated cirrhosis and its complications are a common reason for admission to both ED and then the acute medical take. And therefore it's important that us as physicians are able to manage these patients appropriately. The prompt management of patients with decompensated cirrhosis is vital to ensure they receive the correct medical treatment and are therefore escalated onto appropriate services, whether hepatology or ITU appropriately. And we'll be drawing to everyone's attention the importance of a Basel and a British Society of Gastroenterology care bundle, which is an important tool to guide management within the first 24 hours of the inpatient stay of a decompensated cirrhotic. And the critical thing is that this care bundle has been shown to improve outcomes in other trusts. So one of the most striking things, I think, over the last 40 years is that actually the standardized mortality rates in the UK for those with liver disease have dramatically actually worsened. And that's probably the only organ system that has actually experienced a deterioration in their standardized mortality rates. Of course, we've got better pharmacological drugs for diseases such as diabetes or cardiovascular disease, and new interventions like thrombolysis and thrombectomy for stroke. But in liver disease, there is a paucity of intervention other than transplant. And the focus really is on monitoring patients with compensated cirrhosis in order to make sure they don't develop complications and trying to remove the toxic insult to the liver. So what is cirrhosis? So cirrhosis represents a chronic inflammatory state with associated changes in the liver parenchyma. So on the right, we can see a kind of autopsy specimen of a liver with its nodular appearance, which is pathognomonic of cirrhosis. Historically, it's always been a histological diagnosis and the presence of regenerative nodules within the liver parenchyma. And those regenerative nodules and the chronic inflammatory state lead to portal hypertension and end-stage liver disease. However, there's growing acceptance of the role of imaging in the diagnosis of these patients due to the high risk of obtaining a biopsy within them. And as we can see on the lower right-hand side, we can see the presence of a more nodular liver with ascites. And the causes of cirrhosis are varied. The importance of the causes of cirrhosis is that they don't occur in isolation. Many of our patients with cirrhosis have dual pathology. So as we can see on the left-hand side, and I know everyone hates H&E stains, but on the left you can see normal liver parenchyma with normal liver sinusoids. And on the right, we can see the normal liver sinusoids surrounded by an area of fibrous material with the red arrow and the green arrow being the normal liver sinusoids. Between these regenerative nodules, there's lots of lymphocytes which occur as a result of the chronic inflammatory changes which occur in cirrhosis. So what are the causes of liver cirrhosis? So if you put your suggestions into the chat below, so you don't hear me talking for the whole time. Any suggestions? Yeah, so we've got alcohol, non-alcoholic fatty liver disease, which is associated with obesity, viral hepatitis, metabolic causes that we'll touch briefly on, and autoimmune disease. So that's perfect. So the causes of cirrhosis are varied. They include, in the developed, they're slightly different from the developed to developing world. So mainly in the developed world, we now see alcoholism as well as the impacts of obesity through non-alcoholic fatty liver disease driving the majority of our cirrhotic patients. If we were in sub-Saharan Africa, we'd see hepatitis B as a major driver of liver cirrhosis. And in Asia, we'd see hepatitis C being a leading cause, as we also do in this country in immigrant populations, as well as in our IVDU populations. We've got other interesting causes of cirrhosis, like autoimmune hepatitis and biliary duct disease, so primary biliary cirrhosis and primary sclerosing cholangitis associated with ulcerative colitis. And then we've got the rarer but more medical school relevant diseases of our inherited metabolic diseases of the liver, like hemochromatosis and Wilson's disease, as well as alpha-1 antitrypsin and cystic fibrosis. So, but what is liver failure? So liver failure is categorized into two main types. So you have got acute liver failure and you have acute on chronic liver failure. So acute liver failure is something that we commonly see on the acute medical take in the form of a paracetamol overdose. We have you have a toxic insult, the paracetamol overdose, which leads to a dramatic drop in function of the liver. And in some cases, patients can become decompensated, so jaundice encephalopathic with a coagulopathy. But in the majority, and may require a liver transplant according to the King's College criteria. But in the majority of cases, that liver insult resolves and there is complete resolution with a flat baseline. The liver function returns to normal. However, in some other patients who have chronic liver disease, whether that be due to alcoholism or viral hepatitis or other causes that we've just been through, we've got acute on chronic liver disease. So acute insults can lead to a decompensation of the liver disease and then a recovery, but the baseline is on a downward trend. And these can really be split into two types. So if we assumed this patient was an alcoholic, A may be an incidence of alcoholic hepatitis, which causes a sharp deterioration in liver function, but there is still some physiological in the reserve of the liver, which enables it to go back to a new, albeit lower baseline. B may be another episode of alcoholic hepatitis or a drug-induced liver injury, which leads to another decline to a lower baseline. And C may be an infection which decompensates the liver, leading to a lower baseline. And this leads to two states, what we call compensated and decompensated. A, B, and C may represent acute decompensations in the liver, but the liver returns to its baseline because it still has a physiological reserve. And therefore we can say that it's compensated. However, the liver may reach a point where the chronic inflammatory changes that occur mean that there is no reserve left in the liver, and therefore we move to a decompensated state. So what do we actually mean when we mean compensated or decompensated? We know that the liver has a degree of redundancy to maintain its functions, and therefore we have these two states, compensated and decompensated. Patients with cirrhosis can go many years in a compensated state because there is enough reserve in the liver in order to carry out its functions. And therefore patients predominantly remain asymptomatic. And it's important that we pick patients up in this asymptomatic state because medical interventions can improve their outcomes. And decompensated is when they become symptomatic, whether that be from encephalopathy, variceal bleeds, or ascites. So the focus of management in this chronic phase of compensated cirrhosis is really to remove the insult to injury, so abstinence in alcoholism, or to treat the underlying cause in the sense of a viral hepatitis. It's important that we screen for HCCs, so hepatocellular carcinoma, which can commonly occur in cirrhosis and can lead to acute decompensations. And that's why you'll see many patients with cirrhosis having 6 monthly ultrasounds of their liver to check for the HCC development. And you'll see this, that there is surveillance for the development of varices either through OGDs or using regular blood tests, looking at an FBC and platelet count to assess whether there is a suggestion of bleeding. The importance is that there is a degree of reversibility in the two states, albeit limitedly. So some patients with appropriate treatment can move back from a decompensated state into a compensated state. And the importance is that the development of varices is highly significant and prognostic in patients with compensated cirrhosis, which is why we have a lot of interest in surveillance for them. So what is an acute decompensation? So it's defined as an acute deterioration in liver function on the background of cirrhosis, and it's characterized clinically by jaundice, ascites, hepatic encephalopathy, variceal hemorrhage, and hepatorenal syndrome. Now, medics are very good at identifying causes for medical presentations. For example, in AKI, we like to categorize whether the cause is pre-renal, renal, or post-renal. But in liver disease, there is an absence of this questioning on the acute medical take of why the patient has acutely decompensated. So common precipitants of decompensation include infection, GI bleeding, high alcohol intake leading to an alcoholic hepatitis, and drug-induced liver injury. However, importantly, in 50% of cases, the precipitant of the acute decompensation won't be identified. So as we move from pre-cirrhotic liver disease to compensated cirrhosis to decompensated cirrhosis, we know that prognosis declines during all of these. Oh, so it was supposed to be a question, but it isn't. So the median survival of those with decompensated cirrhosis is only 2 years, while patients can remain in the compensated phase for around 12 years.
Just to say, Ben, if you want to ask a multiple choice question, there's a Zoom version that I can set up, okay?
Yeah, okay, perfect. So prognostication in cirrhosis is based on synthetic liver function and the assessment of end organ damage. And it's done via 2 main prognostic scores. Firstly, the Child's Pugh score, which gives a letter and a number. So the Child's score is based on 5 main characteristics: the bilirubin, albumin, INR, and ascites and encephalopathy. So you've got metabolic function of the liver through bilirubin and the synthetic function through the albumin and INR. We've got ascites and encephalopathy, which assess for end organ damage. And then we've got the MELD score, which also incorporates other factors such as the creatinine, because we know patients who develop hepatorenal syndrome and AKI on top of their acute liver failure have a very poor prognosis. And there is increasing importance of looking at the sodium and its importance in liver disease for a new modified MELD sodium score, and the role, and that is related to the role of the kidney in the renin-angiotensin axis. So we'll now go through a case of a patient that was recently admitted to Charing Cross Hospital acute medical unit. So the case is of a 65-year-old gentleman who presented to the acute medical take overnight. He's got no significant past medical history of note. He works in finance and drinks 1 bottle of wine a day and presented with large volume fresh hematemesis. So what do people think that the main cause here is of his presentation? Yeah, exactly. So it's most likely to be a variceal bleed, given his, so he's had an upper GI bleed. Given his background history of having a history of alcoholism over a sustained period, the index of suspicion would be higher for variceal bleed than a peptic or gastric ulcer. So what are the abnormalities based on this? I know some people are at screens far away so that you can move closer to look at the blood results, but what are some of the abnormalities that are present on the VBG, the full blood count, and the renal profile and LFTs, if you put it in the chat below? Don't all jump at once. Yeah, exactly. So we've got, so if we go through the abnormalities in the case, we've got a HB of 70, so he's clinically anemic due to his GI bleed. He's got a macrocytosis, which is highly suggestive of long-term alcohol use. He's got a significantly elevated lactate of 5.3, which is prognostically poor and indicates poor end organs perfusion. He does have a coagulopathy with an increased PT and APTT, which is common in patients with liver disease. He doesn't, perhaps surprisingly, he doesn't have a particularly elevated urea, and classically, you would normally think about a high protein meal driving the urea in an upper GI bleed. And then you have a deranged LFT. So he doesn't have a particularly high bilirubin of 37, but he does have signs of sympathetic function with an AL, a poor sympathetic function with the albumin being low. So he had an emergency endoscopy overnight, which demonstrated grade 4 varices. Because he had a large GI bleed with the coagulopathy, he received 3 units of packed red cells overnight with a unit of FFP and received a stat dose of vitamin K. The patient was stabilized and was hemodynamically stable when we saw them the next morning, but had incomplete banding of his esophageal varices. So they weren't able to pinch off those varices, all of those varices within the esophagus. And then if we look at the right, this isn't the patient's image, but as a patient image taken off Google, we see these large dilated varices within the esophagus, which look like worms as they were, within the esophagus. So the next question is, what additional treatment would you start on this patient in the acute setting? Answers in the chat below. So he's had 3 units of blood, he's had a unit of FFP, and he's had 10 milligrams stat of IV vitamin K. Yep, so we've got answers as telepressin. We've got, so we'll come on to that. So we'd give antibiotics as well. So we'd give telepressin, antibiotics. And what else would we think about given that he's coagulopathic? IV vitamin K. So the additional treatment in the acute setting would be for IV telepressin for variceal hemorrhage, IV antibiotics, and IV vitamin K for 3 days for coagulopathy. I don't know if Dr. Selvapatt wants to.
And do you mind if I interject? You're
Yeah.
doing very well. So I would suggest that actually IV telepressin and IV antibiotics should have been administered well before the endoscopy, as well as the IV vitamin K. So, you know, a bit like a chest drain and a tension pneumothorax, I would say if all of those have been administered after the endoscopy, there's probably been a failure of resuscitation.
So moving on. So on examination on the post-8 ward round in the morning, the patient was jaundiced. He was confused with an AMTS of 7 out of 10 with evidence of asterixis. He had evidence of gynecomastia. He had abdominal distension with shifting dullness. So what additional investigations should you complete given the patient's confusion? Answers in the chat below. Yeah, so we've got a CT head and a serum ammonia as well. I haven't put the serum ammonia on my slide, but you would do ammonia and the importance of sending it off on ice as well. And what additional management should you complete given the patient's confusion? Answers in the chat below. So you've got lactulose, which the patient did receive. Rifaximin. Any other suggestions given the patient's an alcoholic? So Pabrinex. Exactly. So The additional management we'd want to do is a stool chart with regular laxatives, would consider rifaximin. You'd give replacement IV Pabrinex to treat for Wernicke's, you'd replace electrolytes, and you give IV lorazepam for alcohol withdrawal rather than chlordiazepoxide. And I don't know if Dr. Selvapatt wants to say anything about IV lorazepam versus chlordiazepoxide in...
it doesn't necessarily have to be IV, but the rationale for lorazepam, or ideally oxazepam, which isn't available in our trust, the rationale is that chlordiazepoxide is a longer acting benzodiazepine, and obviously that is metabolized through the liver. In patients with cirrhosis that are already being prone to developing encephalopathy, the issue with chlordiazepoxide is that in the acute medical take, you may not see the issues, but when they come down to the liver ward and the GCS is sort of dropped to 7, 24 hours later, it causes a bit of angst. So the idea being lorazepam is shorter acting, and the equivalent dose is roughly 1 milligram of lorazepam. It's equivalent to roughly about 20 to 25 milligrams of chlordiazepoxide. So it's a relatively easy conversion. I would probably also say that we should be doing CWAR scores for all patients that we're concerned about withdrawal, but particularly the cirrhotics, because actually if you can avoid regular anti-withdrawal agents, that is ideal. And interestingly, although this has never really been published, I would say anecdotally, cirrhotics don't tend to behave in the same way with sort of alcohol withdrawals as your sort of otherwise sort of non-cirrhotic alcoholic. So quite often you don't need as much dosing.
Could you say something about the ammonia question? Should we measure it or not? I agree with that comment.
Prof. Miran, that's a very good question. So truthfully, outside of acute liver failure, i.e. your sort of paracetamol overdoses with ALTs of sort of 10,000 and clotting of INR of 6 and that sort of thing, there's actually no real role for ammonia. And in that setting, the role is if you have an ammonia above 150, then it's prognostically a bad sign, but also there may be a role for renal replacement therapy to try and manage the encephalopathy. In cirrhotic patients, and actually there's a very good recent JHEP paper that basically confirms what we already know, that in cirrhotic patients, ammonia is not a cheap examination that is obviously, as Ben has alluded to be done appropriately, should be arterial and done on ice. Actually, if I were to check the ammonia of everyone on this Zoom call, there may be 1 or 2 that may have slightly raised ammonia. So there is no real role for ammonia, but it's like one of those things. There will be occasions when I may come down to the AMU and suggest an ammonia, mainly if there is still some ongoing diagnostic difficulties, particularly if they have other reasons to be, sort of altered confusion or cognition. So the short answer is no. But there may be odd occasions where I bend the rules.
That is really helpful.
So just moving on. So what features of decompensated cirrhosis does this patient currently have? So if you put the answers in the chat. Yeah, so we've got jaundice, varices with a variceal bleed, ascites, and hepatic encephalopathy. So in this case, what is the likely precipitant of the patient's decompensation of his liver disease? Answers in the chat. So yeah, so the variceal bleed is the likely precipitant of his liver disease. And now some of you have very keenly put this in the chat earlier. So what investigation should be completed within the first 24 hours of care, which we haven't mentioned so far? Answers in the chat. So yes, an acidic tap should be the next thing that the patient should have. So a diagnostic paracentesis or an acidic tap, if he has ascites, and you can do a bedside ultrasound, identify an area where you can do an acidic tap to rule out spontaneous bacterial peritonitis. And SBP is defined as having more than 250 neutrophils per millimeter cubed in the acidic fluid. The important thing is that the CRP may be falsely reassuring in liver disease, because the CRP may not rise because the liver is the site of CRP production, and it's an acute phase protein produced by the liver. So in his case, the acidic fluid was tapped, and it only showed white blood cells of 23. So anticoagulation. So the CT abdo-pelvis with contrast demonstrated evidence of cirrhosis, and we discussed earlier that a radiological diagnosis is sufficient, but there also demonstrated evidence of portal vein thrombosis. And given the patient had a significant varicocele bleed, a risk-benefit discussion was had that the patient shouldn't be anticoagulated at this point. There's lots of, I know people get very nervous, including when I was an F1, about giving patients with cirrhosis VTE prophylaxis, but cirrhosis does have an impact on coagulation. And there are both drivers which drive pro-hemostatic mechanisms, so pro-clotting, and those that drive anti-thrombotic mechanisms, so anti-clotting. And patients with cirrhosis, if not bleeding and who do not have low platelets, should receive routine prophylaxis, as with non-cirrhotic patients, even if the PT is prolonged. So in summary, we have an acute decompensation on the background of chronic liver disease. It's a new diagnosis of chronic liver disease. And given the patient's history, this was a new diagnosis of alcohol-related decompensated cirrhosis, which was Child's B9. The remaining non-invasive liver screen was sent, but was unremarkable, because we know that not only one pathology can drive chronic liver disease, but multiple pathologies. So it's important to exclude any other treatable causes. The cause of the decompensation is likely his varicocele hemorrhage, but there is also the portal vein thrombosis. And the features of decompensation in his case are jaundice, varices, ascites, and encephalopathy. So I just wanted to talk about the British Society of Gastroenterology Decompensated Cirrhosis Care Bundle, which advises and guides management within the first 24 hours of care. And it's an easy to use pro forma, which is readily available, I believe, on the intranet and readily accessible through Google if you type in BSG cirrhosis bundle. And it's an easy to use pro forma when clerking patients with evidence of decompensation on the background of suspected cirrhosis, and goes through a checklist of investigations that should be carried out. It goes through and it provides a guide for you in relation to what should happen in a cirrhotic. So it advises an acidic tap. It advises taking a clear alcohol history, a suspicion of infection. It looks at acute kidney injury and hyponatremia within chronic liver disease, because we know that it is a poor prognostic marker. And we know that the importance of GI bleeding and encephalopathy in the management of these patients. And the emphasis within the bundle, from our experience in acute medicine, is that there needs to be an emphasis on getting an acidic tap within the first 24 hours of the admission to exclude spontaneous bacterial peritonitis. The use of using lorazepam rather than chlordiazepam epoxide for alcohol withdrawal. Suspending nephrotoxics in those with deranged renal function. We're very good when there is an isolated AKI of isolating the cause, but also suspending nephrotoxics, but we do it less, or we're less on it in liver disease. And also in relation to VTE prophylaxis in patients who are not acutely bleeding and have platelets above 50. And therefore the emphasis is on the ascites, that you just need to tap it if it's amenable, and on giving lorazepam rather than chlordiazepam epoxide. So the conclusion is that decompensated cirrhosis is a medical emergency with effective interventions reducing mortality and the length of a hospital stay. When assessing patients with decompensated cirrhosis, We need to identify the precipitating cause of the decompensation and treat accordingly. And we also need to do the investigations to identify the cause. The BSG Basel ALD cirrhosis bundle provides an approach for managing patients in acute medicine within the first 24 hours of care. We know that these patients will be referred from ED and they'll be under the care of acute medicine for at least the first 24 to 48 hours, with specialist input being inputted probably after 24 hours. And the cirrhosis care bundle is readily accessible on Google and the intranet, and provides a rationale for our approach to these patients, particularly overnight where specialist input may not be as readily available. And for cirrhotic patients who fail to respond initially, we need to escalate quickly to medical management, either in a HDU or ICU setting, and that is critical in ensuring better outcomes in our cirrhotics. So that's the end of my talk on cirrhosis. If anyone has any questions, you can put them in the chat now.
And if you don't mind, so first of all, can I say thank you, because you were very generous to say that, to thank me for my input in this. I gather you put this all together quite late yesterday, and I think that's been an excellent talk. Is it possible to share screens? Because actually what I'd quite like to do is show you our own trust guidelines.
Yes, you can. Yes, you can. Just click share screen and it'll open the last one.
So can you see my screen? Sorry, it's always difficult when I've used Zoom to know what people can actually see on my screen.
Yeah, we can see same as you, I think.
Yeah. Okay, good. So on the Trust Internet, if you type in liver care bundles, or liver, it usually will come up. We have adapted the national guidelines to a trust-specific set of guidelines, with the aim of helping all of you guys, whether it be at 2 in the morning when there is no liver around, or during the day and you can't get through to the liver reg for whatever reason. And it subdivides all of the different areas depending on the different issues that you may have, whether it be due to alcohol. What I really want to focus is on number 3. So variceal bleed can be a primary phenomenon, especially if people are drinking a lot. That can raise your portal pressures. But quite often it's a secondary phenomena. And actually it's why on the Cochrane review, the only intervention that was shown to reduce mortality is the early administration of antibiotics. And it's likely due to immune paresis type mechanisms in cirrhotics that allows issues related to gut translocation, causing a heightened immune response within the liver that drives portal pressures. So early antibiotics is really important, and actually the majority of your acute admissions with decompensated liver disease, sepsis will be the underlying driver, and in 50% of them you won't find the underlying bacteria. It may be fungal. But early administration of antibiotics is important, and a lot of discussion has gone with our microbiology colleagues, because obviously there is a concern about giving patients broad spectrum antibiotics off the bat. But the agreement really is that if you have decompensated liver disease, particularly with an extra organ dysfunction, then as a reflex, we should be providing broad spectrum antibiotics. In your leisure, you can read the rest of it. As Ben has alluded to, there's some extra stuff about kidney injuries, hemodynamics, encephalopathy, and GI bleeding. We've also included a few things that don't come as part of the standard national bundles, particularly with regard to nutrition, analgesia, and clotting. There's some guidance on what are the parameters you should be looking at in terms of escalation to level 2 and level 3 care. Since the original adoption of these guidelines, obviously there is no medical HDU anymore, so it's all critical care. And then there is a flow sheet looking at how to evaluate the hemodynamic state of these patients. They are tricky because they don't necessarily mount the same sort of SIRS response as you would normally see, and flooding them with lots and lots of IV fluids is often a very bad thing to do, because they basically push the fluids in all the wrong places. So after 1 to 2 litre fluid challenge, you really need to be looking at parameters like the urine output and the lactate, probably more than the blood pressure and the pulse, and then making assessments as to whether they need further escalations of care. The other thing that we have is an order set, which I think is very poorly used. Not poorly used, it's just probably not known about, and it's just something I wanted to show you. So if you go to orders and click add, if you type in liver, there will be an order set called the liver patient admission. And if you select that, it will give you the standard tests that are in the blue that should be done for all. But then it will give you some sort of written prompts, particularly please ensure a urine dipstick has been sent off, an MCNS. Please do a VBG or ABG to assess acidosis and lactate. Perform an acidic tap. And remember, forget the clotting parameters. If you're using green needle and you can easily get fluid, you don't even need to think about the clotting. And actually, an acidic tap should be seen as exactly the same as blood cultures in a cirrhotic patient. And should be done, before the varicose OGD and all of that sort of stuff. And that should be waiting till after the administration of antibiotics. And then if they haven't had a liver screen within the last 6 months, we say, you can do the additional screening tests. As you'll see, we've intentionally omitted things like ceruloplasmin, which quite often is going to be negative or difficult to assess in the acute state. And we sort of suggest that all patients should have an urgent X-ray and some form of imaging. And if you're doing an ultrasound of the abdomen, please specifically state that you want the hepatic vessels doctored, because otherwise, unfortunately, depending, especially out of hours, we get into the state where they've looked at, say, the portal vein, but not the hepatic vein, or vice versa, and then you have to arrange another scan. So that I don't want to take up too much of the presentation time, but just really to say that there are parameters and there are resources out there to try and help you along. I come every Wednesday to do a ward round on Wednesday morning. If there is anyone that you want me to see, please contact the gastro regs at Charing Cross Hospital, and I'm happy to come and see them on a Wednesday morning. Likewise, you have the benefit of both your on-site gastro regs at Charing Cross, but if you really do need specialist advice, the liver team at St Mary's can be contacted directly. And there's an absolute fail-safe, which isn't too infrequent an event. If you can't get through to anyone and you really need advice, then you can contact me through switchboard. But that's me, and thank you again, Ben.
Thank you. There's a couple of questions in the chat that I think we definitely need your help with.
Okay.
One of them is about albumin. Oh, and this is from Doris. Over what time should we give the 1.5 grams per kilogram of albumin from the Trust guideline?
So what Dr. Dobrans is referring to is in hepatorenal syndrome, the slightly, I'll just stop sharing, then I can, the slightly archaic regime that I'm not sure that there's a true design for why it was that way. The trials were originally done that if they have evidence of SBP, you give 1.5 mg per kg at the outset. So each 200 mils or each 100 mils of 20% HAS would be given over 1 hour. So, whichever time point. I think, Doris, probably for, patients that you're seeing that in particular may have issues with fluid overload and other things that you'd want to avoid filtering. I think we've had these discussions before that you can take a slightly more pragmatic approach. So, if per weight they needed 600 mils on day 0 and the 72-hour regime is 1 mg per kg and they need, say, another 4, what you could probably do is just split that over a 3-day period so that you're not sort of giving them a huge load if you think there's evidence of cardiac dysfunction or if you're worried about volume overload. But the true protocol, but you should document that there's a rationale for it. The true protocol would be 1.5 mg per kg and each 100 mils is given over 1 hour.
Thank you. And then there is a question that came up earlier about alcoholic liver disease and steroids, and from a stopper. Is that history or?
Yeah, it's the revolving question that which still causes some debate even within us as a department. So what Professor Mirren is referring to was a big multi-center study that was performed in the UK, which looked at alcoholic hepatitis, confirmed on liver biopsy, and the historic role of pentoxifylline, which is now an obsolete drug in liver disease, and steroids. And there was a reduction of mortality in the steroid arm, which was barely significant at 0.056 at 28 days in the steroid group compared to placebo. But then beyond 28 days, going out to 90 days, it crossed over and that significance was lost. The advice would be that if you have a patient with alcoholic hepatitis, please let us know early, because we will bring them to Mary's for clinical trials assessment. Now, not all patients will be eligible for trials. We don't always have active trials, but we do have a very strong portfolio of trials, and there are always things that are available. In truth, steroids with the addition of N-acetylcysteine still remains the standard of care for a lot of these patients, with what we call a allele score, which is a delta effectively of their bilirubin over a 7-day period to decide whether they are likely to benefit from ongoing steroids up to 28 days. But what I would say, without dodging the question, it's not a straightforward answer. And if you have got a patient with alcoholic hepatitis, we want to know about them early. We do, I mean, as Dr. Tharakan, I'm sure, will testify, we are proactive about getting patients across the Douglas ward. The last few weeks have been challenging given the current bed state, but where possible, we will bring these patients across.
Okay, so I think the answer for us as general physicians is not to give steroids unless you...
No. They need a full set. It's not like in, say, inflammatory bowel disease or COPD and asthma, where the early initiation of steroids is going to...
Right.
They've got time before they have steroids, yeah.
Thank you. And then there's a question about when to give rifaximin.
So the clinical trials for rifaximin were actually the original New England paper in 2010 odd time was actually the addition of rifaximin with lactulose in reducing outpatient admissions to the A&E with encephalopathy. There's no real good evidence for acute encephalopathy as an inpatient, but actually, because quite often our treatments are limited, i.e. opening their bowels, and if they're in ITU, filtration, we do tend to give rifaximin as an inpatient. What its role in the context of active use of intravenous antibiotics, meropenem and tazocin, how effective is a gut-soluble antibiotic really going to be is hard to know. It is an expensive drug. In truth, rifaximin should probably be something given as an outpatient for encephalopathy. But as I said, we do give it as an inpatient, but I think it should be something that is discussed before discharge as to whether they need it ongoing. And certainly if you are starting it, then they need to be seen in one of our cirrhosis clinics, of which we have 4 at St. Mary's per week.
Great, thank you very much for that. Are there any other questions? And thank you, Ben, for that great presentation. I'll put a recording of this onto YouTube, if that's all right.
There was just an update about Izzy Williams's excellent presentation on medical mystery in Afghanistan.
Oh yes, thank you.
That was the 27-year-old male who was admitted with jaundice, whose LFTs were not deranged, but presented with a high unconjugated hyperbilirubinemia, and had a recent change in diet with increased consumption of broad beans. The outcome of it was that the genetic testing was positive for G6PD deficiency, secondary to broad bean consumption.